In the elderly, may I call and present Professor Dr. Mohammed Jaloudi, Professor of Oncology, Tuam Hospital, United Arab Emirates.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. Good morning. It's always a pleasure to come back and visit Egypt. I'd like to thank the organizers, specifically Professor Hisham al-Ghazali, for inviting us. So now we'll go to the other extreme, breast cancer in the elderly. With Professor Mary Apro sitting in the back, I don't know if I'll do justice to this topic, but we'll try. Facts are 60% of all cancers are in people over the age of 65, and 70% of all cancer mortalities are, again, in patients who are over 65. Look at the life expectancy in 2013. Population is aging, and it's no different in the Middle East and Africa, though the numbers are not quite the same, but our populations are aging, both males and females. And look at the different regions, and you'll see the median age is exceeding 80 in some regions. Again, look at the world for males and females, and you can see the life expectancy, at least in the Western US, is exceeding 80, 81 years for females. By the year 2025, about 20% of all people will be over the age of 65. So we have to really get adjusted and accustomed to treating elderly patients with cancers, as we do better in treating other chronic diseases, diabetes, hypertension, and so on. Patients will come to you with a malignancy of some sort. Quick question: what is the life expectancy of a 75-year-old woman in good health? You would think a 75-year-old woman in good health is elderly and frail, but if you look at the numbers, if this lady has lived to be 75 and in good health, the likelihood is that she will live another 12 years if she's in good health. If she's average health, another 11 years. And if she's sick or in poor health, this lady could still live 7 years. So concept here is what's happening, and by the year 2030, this was termed as the silver tsunami. 1 in every 5 Americans will be over 65. 80-year-olds are the fastest growing segment in the population, and again, the incidence and mortality, as I mentioned before, 60 and 70%. I'm trying to move quickly because I don't want them to stop the slides. I'll try to finish before. What are the perspectives of age? We know young adults come in with a serious condition, the cancer itself, there are no comorbidities and so on, and the main goal is survival. Older adults or older patients have multiple coexisting illnesses, comorbidities, there's variable tolerability to specific treatments, and again, the main goal could be survival or, in certain situations, quality of life. Goals of cancer in the elderly would be cure, prolongation of life, an active life expectancy, and to do no harm. What are some of the important questions in geriatric oncology? Is the patient going to die of cancer or from cancer? And that's a very important question you have to answer before you even start treatment. Is the patient going to live long enough to suffer the consequences of the cancer? Is the patient able to tolerate the treatment? And are there complications of treatment that are more common in older individuals than in younger? And of course, the social network of the patient, adequate support, family support, and so on. But before we go into the breast cancer itself, again, when you treat cancers in elderly patients, you have to take into account the patient population. They have different absorptions, distributions, metabolism, and excretion. This will impact on the delivery of treatments, systemic chemotherapies, targeted therapies, and so on, and you have to take that into account. For pharmacology, as we get older, there's modest changes in the PK changes based on the age. There's changes in variability. If you have comorbidities, there's end organ dysfunction. Physical factors also are very important. If you have chronic anemias, the low albumin, also the physiologic changes that you have to take into account, and the polypharmacy. Also pharmacodynamic changes. There's variability as you get older in age. There's increased susceptibility to myelosuppression, mucositis, cardiac toxicity, and also CNS toxicity. Again, this is from the drugs that we deliver, will add toxicity to the patient. Absorption is a factor. As we get older, there are controllable factors that we could do. Polypharmacy, like medications, H2 blockers, antacids. This may interfere with the medications. And things that we cannot control, like reduced gastric secretion, gastric emptying. It gets longer with age. There's diminished splenic blood flow and decreased absorption of the surface. Distribution is also very important. As the changes in the body composition with age, there's fat content that doubles, decreased intracellular water, anemia, and so on. Liver, hepatic metabolism and age. We know that with age, liver flow is reduced, liver size decreases, and also there's age-related changes in the P450 microsomal system, which a lot of the drugs will be involved in the P450 pathway. Excretion, as we get older, there's a decline in the glomerular filtration rate, and it's one of the good predictors that's associated with changes with aging. There's also additional effects of comorbid conditions on renal function, and keep into consideration the different chemo regimens that you use. And polypharmacy. On average, if you look at this study, patients 74 years of age, median number of medications, they're on about 8, and this could vary from 0 to 17 medications, and a lot of these will have interactions with the drugs that we deliver. What about clinical trials in elderly cancer patients? How is cancer treatment studied usually? It's primarily in the middle-aged young patients, minimal inclusion of older patients, fit patients for these trials. There are minimal comorbidities. They're usually Caucasian. Most of these trials are in Europe and the US. And there's little cancer patients that are treated in the community. Most of these trials are in the cancer center-based institutions. Look at the involvement of elderly patients in clinical trials, and you can see from this publication that as patients get older, the likelihood of being enrolled in clinical trials is very much diminished. If you look at the NCI-sponsored trials in the US, essentially there's hardly any patients that are over the age of 80. What are some of the barriers to participation? You all know them. There's focus on aggressive therapy for most of these trials. The trial eligibility limits the participation, like comorbidities, previous malignancies. There are limited expectations to benefit. The physician's reluctance, and we all do it, to recruit older patients and recommend protocols. And the complicated trials requiring large expenditure of time, and a lot of these patients cannot have extended follow-ups and hospital visits. Again, before we go into the breast cancer, we deliver systemic therapy to young, fit patients, but do you do the same for older patients, and how could you evaluate these patients if they're fit or not? You have to take into account the comorbidity and function. Comorbidity evaluation involves the prevalence in elderly. Can they predict survival? There are various scales that could be used. We won't go into those. Functional capabilities as well, which can predict survival, the daily ADLs and IADLs, physical function, and so on. Some of the functional assessments as endpoints include the alterations in the ADLs, IADLs, and the geriatric response, whether it's frequent falls, delirium, incontinence, nutrition, and so on. The comprehensive geriatric assessment is very highly sensitive to common problems in the elderly, which is the assessment with CGA or the limited VES-13, validating the limited assessment which was done by HURA in 2005, either the CALGB recommendations or memorial recommendations. Is the patient able to tolerate treatment? And this decision is really routinely made based on the chronological age. Now, chronological age is really not the same as physiological age. So a very healthy, fit 80-year-old female, yes, she's older, but she is in good shape, so you should treat her as such and not rely on the age itself. How do we do this as oncologists? And I assume most of us are oncologists. Usually by history, Karnofsky scale, ECOG performance status, and it's an educated guess. The problems with this is it's limited to physical functioning only. It's not sensitive to functional declines of the aging and not validated in the geriatric population. How do the geriatricians do this? It's usually the comprehensive geriatric assessment, CGA, which involves the functional status, the comorbid medical conditions, medications, cognitive function, and so on. The problem with this, it's very time consuming. This could take anywhere from an hour and a half, and it involves a multidisciplinary team effort. So this time-consuming evaluation, I don't think any of us as oncologists have the time to do this, and sometimes we have to basically accommodate. What other existing methods we could do? We could do the Vulnerable Elderly Survey 13 or the mini CGA, which might take a little less time. With that said, breast cancer in the elderly, is it really a more favorable biologic phenotype? We know that there's lower expression of HER2 in the elderly. There's a higher content of ER. and PGR, 87% of patients greater than 87, as compared to the lower numbers, 60, 70 in the younger populations. There's a higher frequency of diploidy, and there's a lower frequency of P53 mutations, and perhaps a better outcome, maybe. What about endocrine treatment? There's less of a role for chemotherapy in the elderly. But tumor stage at diagnosis is more advanced than in younger patients who are less than 65. So it's basically checks and balances. Some are better in the elderly, others are not. Early breast cancer in the elderly. We know that breast cancer is a disease of older women. Incidence continues to rise with growth and aging of the population. Treatment is a frequent problem in the elderly population, and there is poor representation in the clinical trials. So individualized oncogeriatric care plan is based usually on the life expectancy, the comorbidities, level of dependence, and so on. Is there a role for chemotherapy in the elderly patients? We know that adjuvant chemotherapy efficacy decreases with age, and I mentioned some of the problems we have with pharmacodynamics, pharmacokinetics, and distribution, and so on. We know that efficacy should be calculated in the context of comorbidities and life expectancy. Few elderly women with node-negative tumors will benefit from adjuvant chemotherapy, and the chemotherapy toxicity. Older women experience more toxicity than younger women, although toxicity is not substantially higher in healthy older women. This is a generality. Look at this trial. This is adjuvant chemotherapy in older women with hormone receptor negative breast cancer. Adjuvant chemo and survival in older women with hormone receptor negative breast cancer. This is assessing the outcome in a population-based observational cohort by Elkin et al. This is a population-based sample which contained over 1,700 patients. Women were 66 or older, included stage 1, 2, and 3, and both estrogen receptor negative and progesterone receptor negative. Look at the data and conclusions. A survival benefit from adjuvant chemotherapy in older women with hormone-negative breast cancer. The benefit of the chemotherapy is most pronounced in patients most likely to be selected because of high-risk disease characteristics. Again, similar to what you would do in younger patient populations. The risk of the disease, the more likelihood, the higher the risk, the more likelihood the response and outcome. Chemotherapy use decreased dramatically with age more than 52. And women aged 69, approximately 5% of women who were over 85 did not have any, did only get treatment. Why chemotherapy, and is there a benefit? If you look at some of these analyses, you can see that there is definitely a benefit for younger populations, but patients as they get older, there is still a clear benefit. There's no clear trend as to the cutoff, so the benefit continues regardless of the age. What about endocrine non-responsive patients? We know there's a large benefit. Look at the SEER data of 2,700 patients. We know there's improvement in survival by 15 to 28%, and also at ASCO by Moss showed that AC or CMF is superior to capecitabine. Who should get chemotherapy? Again, in endocrine responsive patients. We know there's a smaller benefit for endocrine responsive patients, and you could see the data again with anthracycline regimens in postmenopausal women. Overall survival is increased. There is definitely a benefit in patients who are over 70, and the benefit is largely hormone-sensitive tumors only. If you look at the phase 3 trial for patients 65 and older, weekly epirubicin plus tamoxifen as compared to tamoxifen alone, disease-free survival was improved. Overall survival was the same, but in this trial, the tamoxifen was used concomitantly with the chemotherapy, which, as you know, is not our standard of care. Which chemotherapy? Again, looking at some Sangha criteria, endocrine responsive, 4 cycles AC or 6 cycles of CMF. I'll talk about CMF a little bit later. Endocrine non-responsive patients or uncertain disease, anthracyclines plus or minus taxanes. CMF in the elderly, some people think CMF is a benign regimen combination, but it's relatively toxic and more so in the elderly patients, so less tolerated and less effective than in younger patients. The toxic breath rates could be anywhere to up to 1.28%, so CMF is not a benign regimen and should not be used. Anthracyclines in the elderly, yes, we know it's superior to CMF. There's no age trend, but there are consequences. The 10-year cardiac failure rates in women 66 to 70 is increased. And if you look at the 47% if adjuvant anthracycline is used, 33% if CMF is used, and 28% cardiac toxicity at 10 years if no chemotherapy was there. So cardiac toxicity is there, but with anthracyclines it's increased. Taxanes, 4 cycles of TC, taxotere and cyclophosphamide, it was superior to 4 cycles of AC and in disease-free and overall survival, so this might be a good choice in patient populations that might have underlying cardiac disease, or you think they have a higher incidence of cardiac consequences. So again, at the end, age by itself is not a determining factor for adjuvant chemotherapy. Individualized decision to estimate the benefits, risk, and so on. Which chemotherapies for AC preferred above 6 CMF? CMF is superior than capecitabine. 4 cycles of TC is an attractive alternative. Trastuzumab or Herceptin in the elderly, and in this trial, the analysis of elderly patients from a prospective observational German trial for early breast cancer, and you can see treated with adjuvant trastuzumab or alone or in combination, and you can see the characteristics whether less than 65 or over, and there were minor differences regarding the chemotherapy use. The ECOG performance status, of course, in the elderly would be lower, and the starting median left ventricular ejection fraction, there was also a difference. But at the conclusions of this trial, that is, trastuzumab is well tolerated and can be effectively used in patients with HER2-positive breast cancer without age restrictions. Elderly patients with early HER2-positive breast cancer are more often treated with less aggressive regimens. There are some differences were evident in the cardiac safety and premature withdrawal from the treatment among elderly patients, so an easy trigger to stop the treatment. The disease-free rates after 2 and 3 years are 96 and 91% respectively. So elderly patients with breast cancer appear to derive the same benefit from adjuvant trastuzumab. Surgery, look at some of the trials, small ones, most of these were retrospective analyses or single arm, but some of these trials comparing surgery versus hormonal therapy, tamoxifen, and you could see the numbers are relatively low numbers, but there was no difference in overall survival, but with primary surgery, the local recurrence was the same, overall survival was not significant. And so remember that local recurrence is a problem and for elderly patients, and even for young patients, because it's really debilitating and very painful. The types of surgery, we have breast conservative surgery. It's often less used. The outcome is similar to mastectomy in elderly patients. There's a few data for patients over 70. There's definitely a better quality of life, again, for over 70, and is preferred by most older patients, the breast conserving surgery. Mastectomy, less so. What about the axilla? To address the axilla, we know that the low-risk tumors, node-negative small tumors, axillary dissection, there's concerns of causing comorbidities. There's little influence on the adjuvant treatment choice, and studies showing no inferior prognosis in low-risk tumors when axillary lymph node dissection is omitted. The idea here is sentinel lymph node biopsy is the solution, and again, for high-risk tumors, axillary dissection is standard. SIUG, some recommendations, and you heard those yesterday from Professor Apro. Don't deny surgery for anybody over 70, only on the basis of age. The kind of surgery for older should be the same as younger. The axilla, there's small clinically node-negative tumors, axillary dissection, comorbidity without influencing adjuvant treatment decisions or prognosis, and sentinel node biopsy or procedure is a solution for tumors that are less than 2 to 3 centimeters. For high-risk tumors, axillary dissection. Radiotherapy, if you look at breast irradiation after breast-conserving surgery, and you can see the 5-year local recurrences, whether you do use or do not use radiation, and there's a difference, the 15-year mortality. Again, you can see the differences. Look at the people who are patients less than 50 or over 70. Definitely the 5-year local recurrence with no radiation is higher. The 5-year local recurrence risk again, for over 70 could be 13%. So radiation therapy should be considered in all patients after breast-conserving surgery. If greater than 70 and low-risk tumors, less than 2 centimeters, clear margins, and node-negative hormone-sensitive patients, the absolute benefit is small, and the radiation could be discussed individually, and you could omit that if need be. What about a boost after breast conserving surgery? And you could see, again, with the boost, the recurrence rate is less, so the absolute benefit for survival is is small, if there at all. So it should be, again, a tailored approach. And if you remember, I knew this was coming. Okay, just 2 minutes.
Yeah, you got 2 minutes, Dr. Jaloudi.
With stopping this, actually, we already have wasted one minute. So, from 2010, the CLGB 9343 tamoxifen with or without radiation, following a lumpectomy for patients over 70 years old, a 12-year median follow-up, and you can see the outcomes with ipsilateral breast recurrences with tamoxifen alone versus tamoxifen and radiation superior to there is more recurrences with tamoxifen alone. And the conclusion of this is that in elderly patients, breast cancer benefits of radiation after lumpectomy, it reduced the recurrence is about the same by 7%. There's no radiation benefit on survival, as we mentioned, and omission of radiation after lumpectomy is a reasonable choice for early stage breast cancer. Post-mastectomy, the benefit of radiation is independent of age, and local recurrence reductions at 5 years are about 18%. For greater than 4 lymph nodes or T3, the 10-year survival, overall survival increased by 10%. And for 1 to 3 lymph nodes, it's really more controversial. The SIOG recommendations, I think you heard yesterday, we'll skip that. Hormone therapy, we know there's a benefit even with age, whether it's tamoxifen or aromatase inhibitors. We know the toxicities of each one. Again, the SIOG recommendations, benefit of adjuvant hormone therapy for older is the same as younger. No evidence of age-related differences in efficacy between tamoxifen and aromatase inhibitors. However, more vulnerable to some side effects, and the side effect profile of each one. Comorbidity can be an important parameter in the choice between the different treatments. In conclusion, be aware of the undertreatment, which can lead to inferior outcomes. Be aware of overtreatment. Elderly patients don't need identical therapy systematically, less absolute gain of chemotherapy, radiotherapy, influence of comorbidities, and the most optimal therapy, general prognosis, tumor-related markers, global health status, and life expectancy. Patient preference should be taken into account. And remember that it's not chronological age, but physiological age. With that, I thank you for your attention. I hope I didn't put you to sleep.
Thank you, Professor Mohammed Jaloudi, for your elegant presentation. I think there is room for one question because of the prior time. Please.
Mohammed, fantastic.
Thank you.
You were asking for that, we were saying I'm sitting in the back. No, this was a very good presentation. Very happy that the organizers have given us 2 opportunities to discuss this very important issue. And what Mohammed Jaloudi discussed with you really highlights the fact that we need more work in this area. And I would really urge you all to consider that you push studies in this field. I know that your population tends to be younger, but you do have these elderly patients, and we need to collaborate throughout the world in order to solve this issue. Just one comment. I think that one of the main issues we face in Europe, I don't know how it is over here, is the reluctance of surgeons to discuss with the anesthesiologists cases where surgery could easily be done in patients who have aggressive disease. It's a completely different situation of an elderly that has a small thing that can be easily taken. And I think this is another issue in which we need to do a major effort, because I do see too often patients that are referred to me without any discussion appropriate for surgery.
Now may I invite the next speaker, Professor Sana El Sokht from Jordan.